Okay, so welcome everyone. If you hadn't had you good? Okay. If you hadn't had a chance yet, there is lunch over here. Don't forget, there's some water, so please help yourself. I think I need a chair here to talk in this. I'm a little taller than a microphone. We'll make it work. Well, thank you all so much for coming and taking time out of your busy day to join us. Hope you're having a great show and you're enjoying LA and seeing the stars and having some good food and some sunshine. So I hope you're having a great event. But again, we just welcome you and thank you for taking the time to join us. We're excited about what we're going to share today. We're going to dive into diagnostics, and I think we said the tsunami that's coming around diagnostics, so it's really exciting. And then dive into PET-MR and the future of PET-MR and how it plays into the clinical workplace. Okay. So I'm Nick Karabatsis. I lead sales and marketing for Siemens globally. And so again, it's great having you all here. So let's get started. We'll start with Dr. Munir Ghassani. Give you a little background on him. He's the Chief Medical Officer at United Theranostics, and he's a globally recognized leader in nuclear medicine and molecular imaging. He's made significant contributions to the field with more than 200 peer-reviewed publications and also presented over 200 national and international forums. His leadership spans across many influential organizations. He was a past president of the Society of Nuclear Medicine and Molecular Imaging, that we're here. He's also been chairman across other accreditation, regulatory, and educational initiatives. He's also the system chief of nuclear medicine at Mount Sinai Health System, and he continues to shape the future of precision medicine and theranostics through innovation, collaboration, and mentorship. So with that, please join me in welcoming Dr. Munir Ghassani.
Thank you, Nick, for the kind introduction. And just former system chief of nuclear medicine at Mount Sinai, but I served in that role 2 years ago, and now serving full-time as the CMO of United Theranostics. And I'm still maintaining my appointments there, as you can see here, in neurosurgery and radiology at Mount Sinai. So staying in close contact with the trainees, and education is an important part of our mission, so I can't really detach myself from staying in touch with the residents, still give them all the reviews and do some image review sessions with them as well. You mentioned about the tsunami coming. It's actually, as I corrected, it's here, but it's going to get stronger, and you'll see from the data that I'm going to share you that there's increasing role of imaging as we dive into deeper and deeper into the theranostic side of it. And then the other point you made about the stars, and as you know, the theme of the society meeting this year is Science is the Star. And I would argue that I will not be surprised if in the next 4 to 5 years there's going to be a movie or two centered around theranostics. So hopefully we'll do our efforts to see if we can convince some of the producers to show where the future of theranostics is an appealing topic for some of the movies. These are my disclosures. And it's very simple. I just wanted to show you in our practice how much imaging plays a role. And we call it the loop. You do the imaging, you qualify the patient for therapy, you confirm the delivery, and then go back and do a follow-up imaging to continue to show the response. And also you need to know when to stop or not to proceed if a situation arises where you don't have a patient who is deemed to be beneficiary of the approach that you initially embarked on. So the simple principles, fundamental roles of PET-CT and SPECT-CT, but then the key component is going to be the core principles, applying it to the patient care, and show you how we are able to accomplish that in our day-to-day practice. So let's first go for the role. If this audience doesn't need too much details of this, is that it's a radiolabeled compound for PET or SPECT. So in our practice right now, in addition to the PET imaging, we also have lead 203. We do the trials on those for SPECT as the qualifier, subsequently getting the patient treated with lead-212. And one of the trials that we just have started enrolling the patients is on the DLL3 for small cell lung cancer. Then you have the target expression, receptors, and transporters, and then qualifying the disease burden and distribution. Those of you who were at the morning plenary saw some of the data, and the strength of what nuclear medicine provides is, in addition to an imaging confirmation, it is a robust way for quantitation. So clearly that is a significant component of all of our practice. And then for the therapeutic molecule, you just have the same target, but a different radionuclide, alpha emitter, beta emitter. You saw this morning again on the attempts at I-125 as the Auger electron emitter 3 decades ago, and seeing some promise that it can provide. We have a trial where our patient is coming in 1 week for I-125 in the triple negative breast cancer setting. So we're going to apply the Auger electrons in the treatment as well. And then the advantage is that the target positive cells are getting the treated, and the organs at risk are minimized, having lower degree of exposure to those organs. And this is, I highly recommend, as you know, Ken Herman is now the new incoming editor-in-chief of JNM, just announced today. And we have published together some of the articles, but I like this particular one where in Lancet Oncology in 2020, he just goes through the history. And one of the things Michael Hoffman also shows in his graph of how the higher SUVs are so much predictor of a positive treatment response. And I remember the one that he highlights is a thyroid cancer patient with the I-124 PET showing an SUV value of 800. And if you can get that degree of expression, you know that these patients stand to benefit tremendously from the targeted treatment that gets to there. And there are data that it shows that 85% overall survival. This is something that started in 1941 and still is the fundamental basis of what we do today for other types of cancers. And here's one of my own patients whose imaging we did with I-131 as part of the dosimetry protocol. And all of those lesions were confirmed. Post-therapy dosimetry showed each and every lesion on a SPECT-CT. We have a niche traceable source that allows us to quantify the actual delivery, in addition to confirming it with pre-therapy dosimetry that actually it is the dose delivered to that area. Inevitably, we find that almost 80–90% of the lesions, we see that there is more delivery compared to what we had predicted. And when we look at the post-therapy SPECT-CT. Interestingly, it still needs to be looked at more details, but even those patients in whom we have seen the lung metastasis of thyroid cancer, and predicting the dosimetry showing that it may be 3 or 4 grade delivered to the lungs, but when you do the post-therapy, it's actually less than that to the lungs. So this is something that we need to look at further to see if adding a SPECT-CT to close that loop, does it really improve your therapeutic index predictions compared to what you may have done with either pre-therapy PET-CT or SPECT-CT in those patients? And you can see on the follow-up on the right that all of those lesions that were seen before have completely resolved. And this was a perfect correlation with the thyroglobulin value of 0.8 on the post-therapy follow-up that was done about 9 months later. And then for the general structure, again, this audience is very familiar with the ligand, linker, and chelator concept. So I won't go so much into details, but Marty Pomper this morning talked about no clone left behind. I would add and say that nothing in periodic table left behind either at the same time. That's how the innovations are taking us there. So what are the general advantages when we apply this in our practice for PET-CT? We do get quite a few requests for standalone imaging that are not part of our theranostics pair. And in there, you have a superior spatial resolution, higher sensitivity, better quantitative accuracy, and faster acquisition times. Compared to what we started with Mike 25 years ago, when we got the first scanner, it was a 1-hour protocol per patient. And look where we are, less than 10 minutes is very normal nowadays for completing the entire PET CT. And then, of course, the digital detectors and time of flight adds significantly not only to reducing the time, but also better quantitation. When it comes to theranostic specific, again, better lesion localization, including identifying targets that are sub-centimeter in size, getting the SUV measurements for patient selections. Again, we have a number of articles showing that you can put the patients in those quartiles based on the SUV values for prostate cancer-directed therapies. And then whole body coverage in a shorter time, having more comprehensive baseline exam, and also interval imaging for response assessment. For SPECT CT, on the other hand, there's a greater accessibility. We were just talking earlier today about the US Department of Energy gave us a grant to go and identify Ghana as our target country for peaceful use of radioisotopes, marking the 60th anniversary of Non-Proliferation Treaty. And when we went there, we identified Mike Sateke, mentioned to us, said, oh, well, we have a possibility of getting the first PSMA-directed therapy with lutetium-177. But in the entire country of Ghana, there is not a single PET scanner. So what did we have to do? We actually did a technetium PSMA scan to identify that patient. Now, obviously, you can argue that the comparison between the PSMA PET and SPECT is an area of debate. But in identifying the patients for therapy, the expression confirmation was sufficient for us. And that patient actually did very well. And we were able to deliver the lutetium-177 PSMA in an area where there was no availability of a single PET CT scanner. We can image therapeutic isotopes, longer-lived isotopes for delayed imaging, multiple time point, multiple photo peaks, so you can add up to improve your count profile, and then establish infrastructure across the globe. For theranostic specifics, there is, again, wider availability to apply theranostics in places where they don't have the PET CT. And I would argue that the molecules such as lead-203 will further enhance that ability for places to practice theranostics, which is otherwise not feasible. Post-therapy imaging, in our practice, we almost every single patient, with maybe 1 or 2 exceptions so far, has agreed and has finished 4 time point post-therapy scans. And I'll show you a couple of examples of how powerful that has been for us in terms of treatment paradigm. And some of the cases really highlight that point. And it is cost effective because lower equipment and operational costs as well. So both of them have a role to play. So let's look at some of the cases. So this is the first case, and I'll give you a little bit of background on our affiliations with the Mount Sinai and the practice of neuroendocrine. It's one of the most premier centers in the world in the treatment of neuroendocrine tumors. And when we look at the number of cases that are coming in, it's just remarkable how many patients. Every week there is a tumor board on Thursday evening, and on an average about 10 to 12 neuroendocrine tumor patients are being discussed every week. And it is not uncommon where we get the request for applying them in a unique setting where there is a protocol where you have 2 isotopes available. So can you maximize the complementary role of these 2 in terms of the clinical situation that is at front of you to address? And one of the things we have found is that particularly when you're looking at staging or for unknown primary, we find that the copper-64 dotatate is very valuable. In our practice at United Theranostics, these patients are coming for dosimetry calculations, so they're all getting copper-64 dotatate as well. So look at this case. You can see the MIP image. The patient is a GI surgeon and had abdominal pain, gets the ultrasound, they find multiple lesions in the liver. And so easily they can direct a biopsy needle, comes back as neuroendocrine tumor. And the patient undergoes CT scan afterwards for staging. And at that time, the CT scan shows that there is a big lesion in the duodenum. And it's not uncommon for duodenal primary to go to hepatic targets. So it was concluded that there's a primary in the duodenum and metastatic disease to the liver. The case is being discussed on Thursday night. The patient is in the OR schedule for Friday morning. And we're looking at the details, and my sister, who at that time was at Mount Sinai, and we were preparing the cases for tumor board. So Nasreen points out that this lesion in the duodenum had a complete 360 fat plane around it. So she argued, she said, how could this be a duodenal primary when there is no stalk attached to the duodenum? And then at the same time, we're looking at the MIP image and something catches our attention. And that uptake, while the rest of the GI uptake is there, but you can argue that this stands out very clearly. So we looked at the corresponding slice of the CT, and you can see that corresponds here. You can see in the fusion image, but there's nothing there. And this patient had already undergone a capsule endoscopy just to make sure that that duodenal lesion and something else is not going on. The capsule endoscopy was negative in the small bowel, but we see this. And so at the tumor board, we drew the attention to the very established, world-famous neuroendocrine surgeon saying, make sure that you palpate that lesion and see if you find something. Maybe we have a false negative, maybe we have a focal inflammation, but you need to at least make sure that you exclude that possibility. So knowing that this was the case, he starts palpating from ileocecal going more proximally. And as soon as he comes out of the OR, he calls me and he says, guess what? I found a lesion that doesn't look like more than 2 millimeter in size. And then we waited for the path report to come out. It turns out there were 2 1 millimeter each lesions that were sitting next to each other. I would think that we were fortunate. I'm not sure if they were 4 or 5 centimeter apart individually. Would they have given us enough signal amplification and cumulative counts to show up on our pixel? We don't know. But those 2 lesions, 1 millimeter each, sitting next to each other, gave us that signal that confirmed and predicted. And this patient was able to get the primary removed and not leave it behind, which would become after the fact declaration of patient's outcome in the future. And it's not uncommon for the primary neuroendocrine tumor of small bowel to be multiple. We see that very often in our practice, that these could be multiple. It doesn't have to be a single primary. So fortunately, we were able to pick that out. And happy to report that this was about 4.5 years ago. This patient still comes for annual dorotate PET. And thank God it has been negative so far. So this imaging made a huge difference in the outcome of this patient. The second case is, this is what I was referring to have the advantage of multiple time point imaging. And it is remarkable. If you only used the PET to decide this patient's likelihood of response to treatment, I can show you there are, just let's focus 3 hepatic lesions. The patient has a few bone metastases as well, but they are taking a lot of expression of dotatate, so that's not a problem. The problem is this lesion. You can see a very bright expression here, not so bright here, but there's only faint expression there, but it did not look like it was a reconstruction artifact. And so we put the CT in a liver window to get a better narrow window to figure out, is there something going on? Mind well that this is a non-contrast CT, but we found that there is a hypodense lesion. And that lesion is showing mostly photopenia, a little bit of uptake along its medial margin, and maybe a little bit along the posterolateral margin. So based on this, oftentimes people are talking about combination. Is this a potential candidate for a liver-directed therapy? Usually neuroendocrine tumors, we don't give Y90, we give bland embolization to these patients. So the question would be, should we be adding bland embolization to make sure that this does not become the determining clone that Marty Pomper was talking about this morning? We said, well, not so soon. Let's just look at the post-therapy scan and we'll figure out if this patient needs to go for that subsequent liver-directed therapy. And to our great surprise, compare the MIP here and then look at the post-therapy SPECT-CT. Now, this is 7 days post-therapy. I don't have a 24-hour PET, but that 24-hour PET looked 24-hour SPECT-CT just looked like a 1-hour dotatate PET. So based on that, you would have predicted that this patient is not going to respond to that hepatic lesion. But on the 7-day post-therapy scan, when we saw that, we decided not to refer this patient for liver-directed therapy. And this is a perfect example of what we are seeing on a 1-hour PET is not enough, which is precisely why we have switched to copper-64. We do multiple time point PET as well to make sure that some of the lesions that may be non-avid at 1 hour, do they become avid over time? And that actually gives you a closer approximation to the treatment response after therapy. Here is the actual comparison image, and look how transformative that experience has been. You have complete photopenia in the immediate image, but a 7-day post-therapy delivers the isotope to the entire liver lesion. And this was about a year and a half ago. This patient completed all 4 cycles. And even after about 6 months of completion, her chromogranin A is still continuously dropping. We see these patients on our follow-up every month because they prefer to come to us for lanreotide administration rather than going to their oncologist. And fortunately, in our community, the oncologists are so overwhelmed that they readily share the patient care with us, and we step in and provide that necessary void where these patients don't, the physicians, the oncologists don't have enough time to continue to see, and many of them see 40 to 50 patients a day. So that also gives us the opportunity to follow them. We do the pre-therapy labs, pre-consultation labs, and then see them. Most recently, I saw her about 2 weeks ago, and their chromogranin A levels are still dropping. And we will be performing a 6-month post-therapy dotatate PET to see what happens to that liver lesion. And then the other lesion that I showed you that had less expression here, again, on the post-therapy scan, it's very robust expression as well. So it's something to be said about not using too prematurely the data generated from 1-hour PET into determining the treatment response to those patients. Continue to follow these patients, do post-therapy SPECT-CT if you have the capability, but make sure that you delayed one. That will give you a better idea of what the lesion uptake is like. The third case is a 73-year-old with PSMA, lutetium PSMA therapy. This is a patient who's coming for treatment selection. And you will often find that many of these lesions have complete lack of either lytic or blastic skeletal lesions. So the typical teaching was that every time you look at the prostate cancer metastasis, expect the sclerotic lesion to be there. We find that especially in the earlier stage of the disease, many of these lesions are completely isodense to the skeleton. That brings up the point of what would a bone scan show if they are smack right in the middle of the bone marrow and there is absolutely no cortical lineage to that lesion. Would that cause enough osteoblastic response for the bone scans to be positive? And the answer is no. To the point that NCCN guidelines about a year and a half ago, under the leadership of Oliver Sartor, actually made a statement that you do not need bone scans or CT scans to go to PSMA PET in a patient with expected indications for prostate cancer. Another same thing, there is maybe a subtle lytic lesion which is showing the uptake on PSMA PET. And another example, completely isodense marrow-based lesion, but it has clear uptake of PSMA on fusion image. So the idea is that not all lytic lesions are the same. This is another example of a patient with metastatic breast cancer. And this patient has both treated multiple myeloma and breast cancer. And how do you separate out what is what? That's where the imaging really plays a remarkable role. Because on the FDG PET, where both the metastatic breast cancer is a biopsy proven to the bone, and that has the uptake, but I'll show you a couple of myeloma lesions that are completely negative on FDG PET. So this is likely, I don't have the biopsy proof to confirm it. You can't go and biopsy every single lesion to prove what you're seeing, but in the tumor boards, this is what we do typically, is that we concur based on multiple lesions, and a couple of them don't show the expression, they are most likely lack of metastatic disease. So you can concur that this is probably a treated multiple myeloma, but this one is the active metastatic disease. And interestingly, this patient also has a fibrous dysplasia, which that lesion is right here, has no uptake whatsoever. I'm done. Just to show you that when these patients come in and are treated in the pre-therapy setting, in the pre-chemotherapy, we are seeing a remarkable response. So this is a patient who wanted to, the lifetime dream was to go back and hike in Swiss Alps. And this patient's PSA was about 86. It's 0.2 after completion of treatment. And this is only after 4 cycles. He completed the 6 cycles, and there's no detectable lesion whatsoever. It's about a year after completion of therapy. So we need to continuously, in summary, iterate the theranostics precision loop that I mentioned, a cycle of care involving identifying targets, delivering the treatment, verifying those results, and then repeating the whole process if the response is favorable. And then practical applications of PET-CT and SPECT-CT are poised for continuous expansion, driven in large part by a rapid integration of theranostics in our practice. We must prepare for increasing complexity of the cases that I showed you, and the effective practice will require clear understanding of technology limitations. If the expression is not there, you confirm on a delayed imaging, it's still not there, then either abort or add another form of therapy. Increasingly, I think we will move towards a combination therapy for various reasons that are beyond the scope of today's discussion, but another day we can talk about how combination therapies are the next frontier in theranostics. Thank you.
Thank you very much. It's exciting to see the power of multimodality and new advancements in radiopharmaceuticals and therapies play in the clinical workflow of patients. That was awesome. Thanks for doing that. Okay, now we'll transition over to a discussion around PET-MR. And I'm very pleased to introduce Professor Fernando Boada. He's a professor of radiology and associate chair for the Basic Science Translational Research and director of the Lucas Center for Imaging at Stanford University School of Medicine. Professor Boada is one of the key voices pushing the boundaries of PET-MR today, especially when it comes to advanced reconstruction and motion correction. His team has been working on new approaches using MR-derived motion information to simultaneously acquire PET to remove motion blur and improve quantification of the PET signal. In addition, his lab has developed techniques to quickly remove partial voluming from PET scans using MR-derived anatomical information and thereby improving the quantitative accuracy of PET scans. He is also very active in building collaborations across institutions and translating innovation into processes that improve clinical and research workflows. Today, he will share his perspective on the new PET-MR, on where PET-MR is already delivering value and where he sees the next wave of impact in the future. So please join me in welcoming Dr. Boada.
Let me start by thanking all of you for being here and for Siemens to give me an opportunity to come and share with you my experience with this, what I consider to be a very unique platform, which started about 14 years ago for me. So I'm just going to tell you a story. And this story is a story, as my disclosures, that has some interesting sides to it. Some of it is basically some of the misconceptions about what the technology can do, and then some of the opportunities that actually the technology can provide for you when you use it the way that it's supposed to be used. And I will illustrate all of that to you guys basically with examples, lots of images. So let me just start by telling you a little bit side story here. You all know PET-CT. PET-CT as a technology was actually an afterthought. It was basically a comment, as it happens in scientific circles, when one scientist runs into another and says, oh, you know, there is a lot of space behind this machine. Why don't we take those two of these and put them together and see what we can do? At the time, the NIH did not think that this was a big deal. What's the problem? I mean, you can take one image or the other, put it on the same screen, and there's no big deal with it. But the rest is history. As you know, you cannot buy a PET-only machine anymore. After this technology was introduced, PET-CT basically the king for doing these things. The first example of hybrid technology. It's not the only one, but by necessity, it had to be done on what we call sequential imaging. Basically means you put a patient in one position in one of the scanners. Let's see if I can get this going here. And that could be the PET part. And then you move it. And then you acquire the CT part. And then you put the images together. MR-PET was not like that. It was a purpose-built system with the idea of trying to capitalize on the exquisite high spatial resolution that MR can provide and the incredible sensitivity that PET can provide to provide information about very complex metabolic processes. Really, the impetus came from the brain, but obviously it has applications in the body, as you all know. Now, the first generation of MR-PET machines were introduced starting in 2010 with the Magneton, the Biograph MMR, and they all use whatever the latest technology for detector, for PET detector technology was available at the time, and whatever they knew what to do regarding the gradients. Integrating these two technologies is not easy because charged particles, positrons, they move inside magnetic fields. And so you need to be very, very thoughtful about how to do this done. But this is basically what was available back then. And is available up until basically last year, when the new generation of the second generation, what I call the second generation of PET-CT scanners was introduced. So what did we learn from this? And this is the story that I want to try to share with you guys. So you talk to people that have MR-PETs, and they're doing what's most commonly done. They'll tell you that the acquisitions are very slow because they are done doing the PET part, and people are putting all these, MR sequences that take forever. And for the second generation of machine, this is really no longer the case because what happened now is that the MR technology has gotten to the point in which you can acquire the MR signal that you need, the MR images that you need, much faster than you can acquire the PET images. And I want to show you some examples of that in a second. And then there was another misconception, big one, that actually happened early on in the development of MR-PET, and that is that the quantitative accuracy of MR-PET was bad because we were using MR-based attenuation correction. And I'm going to delve into that in a little bit in a second. Now, for the second generation of systems, it turns out that if you have time-of-flight technology, you can generate the equivalent of a transmission scan that is an attenuation correction that is based on gamma rays as opposed to X-rays, which is not the gold standard, basically for free. And I'll show you what that looks like in a second. Okay, so this is the new machine. I'm very excited to have seen this come to fruition because it will eliminate a couple of the problems that we learned about with the first generation machine. Basically, speed is important. And so this machine basically improved the speed of acquisition in MR by more than 50%. So gradient strength is pretty high. Time of flight resolution is likewise very high. It's basically the highest that you can get over there. And it has built-in motion tracking capabilities. And I'll show you how that is important in a second. All right, so I'm gonna show you examples for MR-guided motion correction for both rigid and non-rigid examples, and also what we call anatomically guided reconstruction, and that is how you can use information from MR to improve the spatial resolution of the PET images and basically improve the sensitivity, your ability to actually see lesions that you couldn't otherwise see on a regular PET scan. All right, so first, what can you gain from the second generation of MR PET scanners? Well, this is an example of what you can do right now with the tools that we have developed in recent years. You can do an entire neuroexamination, 1 millimeter isotropic, in something like a minute, right? So this is an extreme case, but you can definitely do what you need to do on a clinical setting in a comprehensive neuro protocol. It will probably take you about 10 minutes. That's it. If you're spending more than 10 minutes, then you need to talk to one of us, and we show you how to do it. It's fundamentally, the minute that you have gradients, like the gradients that this second generation of systems can provide, you are in good shape. And this is the other one. What to do about the attenuation maps. It turns out that X-ray based attenuation correction is not the gold standard. The gold standard is gamma ray based attenuation correction, because the gamma rays is what you generate when you do PET. And but X-ray based is okay, as was demonstrated in this paper. Turns out that you can get attenuation maps for free if you use time of flight. And you haven't seen these make it to the current generation of PET scanner prior to the Biograph 1, simply because the spatial resolution of these maps is not very high, owing to the fact that your time of flight resolution is on the order of about 400 picoseconds. If you take that and reduce it by a factor of a half, then this problem is not really there anymore. So some of these misconceptions about quantitative accuracy and so on, you need to take in with a grain of salt these days. All right, so motion correction. MR PET signal acquisition being simultaneous allow you to basically acquire information about the distortion of the body for free using MR-guided or MR-based signal. And in PET, it turns out that if you know what the body is doing, you can take your lines of response, you can modify them in a way during reconstruction so that the frames that you're acquiring at different positions during the motion of the body are automatically registered to a reference frame. For that, what you need to do is basically know what's going on inside the body. And you can do that with PET-MR with two different ways. One of them is that you can make the sequences, the MR sequences, to give you the MR information by building in MR tracking information within the sequences. Or another one is that you can have sensors within the system giving you that information, these external sensors. So one example of it is the so-called biometrics, which we also call the piloton. I will describe that to you in a second. That the new generation, the second generation scanner from Siemens actually has. There are advantages to each one of those, so I'll show you some examples so you can basically see what you gain or what you're missing in one of them. So the piloton, this is what the new generation of machines is using. It's based on the fact that you take a little radio frequency signal and you play it in the presence of an MRI acquisition. This radio frequency is going to interact with the body, and so the body is changing shape, the electrical impedance of the body changes, and then the signal that you receive when you measure it is going to also oscillate. And so this is an example of what the actual data looks like in some of the experiments that we were doing early on when we were looking at this technology for in collaboration with Siemens. And so this is the signal from the body. This is your body, and this is this reference signal that we're playing in the scanning room. Then you can do a low-pass filter and eliminate the signal from the sensor, and a high-pass filter to isolate this one. And then when you do a statistical analysis of the signal, you can see that the tracking information about the respiration is actually in there. And then you can do a technique that we call respiratory reordering to put these images together, and then basically you can get the motion of the object essentially for free. And then you can use that to register all the frames to a common frame, or if you're interested to see what the PET lesion is doing with motion, you can also do that. But this is very easy to do. This is actually one of those examples in which you can spend one afternoon setting up the experiment and it actually works, which I usually tell my students that if you do an experiment and it works the first time, you gotta be worried about it. This is the exception. And this can be reproduced at other sites, so this is actually very reproducible, and again, it's already a built-in feature within the new system. Another way that you can do it is that you can build in the motion information into the sequence. The advantage of doing something like this is that you can tune it. Is that essentially you're having a patient for which, given the patient size or whatever the patient is doing, you need to do some tweaks, you can actually do that. This is very sensitive. It's so sensitive that you can actually see the dichotic notch on the cardiac signal in here. And it gives you images that now depict basically the cardiac and respiratory cycle. And again, this is all for free, where you are acquiring your signal. And then you can go on, and then this has tremendous benefit when you're looking at small lesions. Basically, this is a small long nodule, and you can see essentially a reduction of 50% in the signal associated with the motion blur, that in the minute that you take the motion information and use it, the problem completely disappears. And as you know, in the lungs, SUV bigger than 2 is a malignant lesion, and so this could have been read as a benign lesion just because you didn't have the right way of acquiring your data. But the other thing that we learned from this is that we will run into cases that cannot look like this, in which we throw all our tools into it, and then basically we don't see much of a change. So we were puzzled a little bit about why this was. And this is actually data that we collected with you, Munir. This is some cardiac ammonia scans. And in the cardiac ammonia scans, you could see sometimes that there was an improvement in the depiction, for example, here of the papillary muscle, but then in some cases, the gain wasn't all that great. So we scratched our heads for a while to try to understand where this came from. And it turns out that the way that we do this motion correction is that, we get these images and we use this technique called optical flow that essentially take the different images and calculate some deformations in between them. And the problem is that when the acquisition of your data is too slow, you get these undersampling artifacts that basically spook the optical flow calculation, and then they give you essentially bad motion maps. When you have bad motion maps, you cannot correct the images. And this is what you see here, essentially, when you do actually like a low-rank decomposition, you can see that all this stuff in here is all basically fake. And so the way to remove this problem is to essentially do the reconstruction in such a way that the generation of this motion registration transformation actually happen during the reconstruction of the image. In other words, you're going to calculate some motion vectors that are consistent with the data that you measure. Or the other possibility is that you increase the acquisition speed. And it turns out that both of these things are possible with the new generation of system. And essentially, when you increase your acquisition speed, and this is actually a computer simulation to demonstrate just these effects. If you operate with the current generation of system, you can get into situations like this, in which the error associated with the misregistering this frame is very large. When you increase the acquisition speed, you'll be basically down in this regimen. So you can basically reduce that error by about 50%. But if you use the proper way of calculating these deformations, you'll be the orange bar, and you can really, really compress limit the error that this introduces. And so you have a speed. Obviously, you can use what we call case-space trajectories that are much more efficient for this. And these can actually produce these kind of motion maps very nicely without basically any imaging artifacts. But you need gradients. And that's where the new generation of systems come into play. With those gradients, you can do it. With the previous gradients, you cannot. So, moral of the story, first generation, you could do the calculation for the motion state during image reconstruction, but it's time consuming. With the second generation, using some of the built-in software features, you can actually do much better. And then acquisition speed, first generation didn't really didn't have what it needed. The second generation, it is there for you to use. All right, so I'm going to use the remaining time that I have to explain to you and to demonstrate to you this technique that we call anatomic guided reconstruction. And here, what we're trying to do is essentially, for the nerds of you, here's one equation and you want to know how it's done. The idea is that MR has very high resolution, PET does not. We can get the spatial resolution for the MR images using during the PET reconstruction, and thereby improving the resolution of the PET images, which makes the detectability better and also reduces partial volume errors, so increases your accuracy. And so this is not a new idea. This has been around, as you can see here, way before the MR PETs were introduced. But when you couldn't acquire the data simultaneously, it became kind of like a logistical thing. You need to collect an PET image, you need to collect an MR image, and if the patient didn't want to do it, then it never got done. When we got the MR PET, we realized, well, all of a sudden we can collect this data for free. Let's see what we can do with it. So we went ahead, we collected, and sure enough, you can go from this to this very easily, and you can calculate bias errors and all the rest of it. But I'm always interested in what I call the why bother test. I can do all these cool things, but do they really make a difference in the clinic? And this was the first example that kind of like brought the case home. And this is basically an epilepsy patient. And when you're trying to diagnose epilepsy with a PET, what you're looking for is hypometabolism. This is a decrease in signal intensity. And this is your typical case of left temporal lobe hypometabolism. But in this particular case, it turns out that the insula is also involved. And we call this the kryptonite case because what happens in cases like this is that you don't resect the insula, the prognosis is really, really bad. You all go ahead and only resect this temporal lobe, the outcome for the patient is not going to be as good. And the reason why you cannot tell the involvement of the insulin here is because partial volume, and you have a lot of uptake on the putamen that basically bleeds into the insula. So this was the first example that basically showed us that this has a clinical impact. And after seeing this, we see many. This is another example in which you couldn't even see the lesion here, and it was clearly noted in there. And so because of this, we were interested in actually using this in the clinic. But this was one of those reconstructions with a funky formula that I show you, and it takes a while for you to go through this. So I was interested in making this practical. And so what we did is that we trained a network to how to do that. And then when we trained the network, now we could do this basically in seconds. And so this is the way that this is done these days. We implemented this at NYU. And basically, the way that we implemented it, the patients went in, they had the scan. The minute that the scan was done, these images will show up in the packs within a couple of minutes. And after I left NYU, every time that the server went down, I would get a phone call in the morning. Hey, the server is down. We have like 15 cases that we need to read it. So this is the way that this is done. One of the questions that people will tell you about this technique, it is so-called bias, and this is like people worry about the fact that you can have a feature on the MR image that then might show up to be a feature on the PET, but it's not existing on the PET. Well, it turns out that every image that you collect in MR, in PET, they're biased because you don't have an infinite amount of data. The question is, do you have the training to recognize the bias? And in MR, these are examples of MR images in which you have flow artifacts, both in the body or in the brain. And if you're trained properly, you don't lose sleep over these ones. For this technique, it's pretty much the same thing. Essentially, what you're doing is that you're extrapolating data. Because you're extrapolating data, if you create an artifact, this artifact is going to look like a false edge. Very easy to find out. So again, there's no reason to waste any sleep over this. And the people that are using this in the clinic, like the practice at NYU, they just basically use this thing every single day. Accuracy, these are examples of analysis, parcellation analysis that we did over a number of patients, both regional and over subjects. Basically, you reduce your partial volume errors. So accuracy actually increases when you use these techniques. Another thing, which I think is very important for this, is the fact that you can throw away about 95% of your counts, as is demonstrated in here, And the image quality in the conventional reconstruction, you can start seeing a lot of artifacts. And the image quality on this anatomical guide reconstruction is basically the same. And again, it comes for free from having the MR information and using it during the reconstruction. And of course, this works for any tracer that you want to do. This is examples about different tracers at different institutions, different population. This is a pediatric population right here. Different cases, different more sophisticated kind of like research tracers like TSPO as well. This technique was so successful over at NYU that they have done well over 5,000 cases. What we learned from that is that the accuracy is significantly improved. You can really take care of partial voluming. Hypometabolic lesions, where essentially the PET signal is too low or blurred out from the across the field of view, you can increase the sensitivity for detecting those for about something like 40%. Because it's simultaneously acquired data, the integration into the clinical workflow is basically seamless. You don't really have to do anything. You have to set up your protocol so that the machine knows that when you're done, you want these two images to go together because you have your choice of MR sequence that you can use this for. Obviously, MR co-registration and no motion is needed for this. And it is essential that you have this registration to be done with MR. And the reason why it needs to be done with MR is because you can get MR, motion tracking information with PET when you have enough counts, as in this example that you have here using FDG. But when you use tracers where the amount of counts that you get is lower, or as we're doing nowadays in theranostics, where you have very specific tracers that only go into very selective region, you're not going to have enough counts to get any accurate motion information. And so even though for some of the more traditional tracers like FDG, you might have sufficient information to track the motion with PET-based signals, when you're trying to get really fancy for theranostics, that's not going to work. So the only way to go is that you use MR, because MR can do this again for free. And this is an example of the built-in tool called SAMR that is part of the new second generation of MR PET scanners that Siemens just introduced, in which essentially what you see in this particular example is that you have somebody that's moving a lot in all kinds of different ways. And if you track the information with the MR system, you can basically correct the images because you're doing it in real time. And obviously, for patient populations such as Alzheimer's, this is very important. These patients do move a lot. And these are the kind of gains that you can gain when you can actually do this. Basically, your ability to detect uptake in the cortex, which is the way that you differentiate a positive or a negative case, it increases significantly when you do this. This is an example, a comparison between the conventional PET reconstruction and the anatomical guide reconstruction, and you can see that the gains are just essentially significant. And just as a teaser, obviously, once you can take care of the motion correction problem in the body, you can also do this in the body, and then you can go for situations like this. This is what you get commonly to something that looks like that, and again, for free. All right, so with that, this is my summary. And one way to exemplify it is that MR PET is not equal to MR plus PET. It's bigger than MR plus PET because you're gaining more. You're doing things that you couldn't do otherwise. The first generation system demonstrated the potential of the technique, and this one is going to enable revolutionary applications for basically improving detection sensitivity and your ability to make more accurate diagnosis. And with that, I would like to just basically end by acknowledging a number of the people that throughout the years and have been involved with this effort, and thank you for your attention.
Thank you very much. It's exciting to see how the technology changes in PET-MR are really impacting how to make PET-MR more important through your standard workflow. So super exciting. So I think Dr. Bawada and Dr. Gasani are welcome to answer a few questions if you have any. If you get a minute, I would selfishly ask you to please come by our booth. It's not hard to find. If you go and look to the left, you'll see a big Siemens booth over there. You can't miss it. Come over and talk to us about our whole portfolio in MI. I know we're super excited about where we are today and the future, about radiopharmacy, PET-MR, PET-CT, and also SPECT. So thank you all again for coming. We appreciate all your time. Have a great show. Have safe travels home, and enjoy the rest of the time you have here in LA. So thank you very much for coming. Appreciate it.